All right. Hello, everyone. We're live. Got episode 5. Miss Ruthie's in the studio. We're going to chop it up. Ruthie's one of our more tenured instructors, but this episode has been in the making for a very long time, and Marty and I really see this as an opportunity to gain some perspective from a ER nurse and to see if there's any opportunity for pre-hospital professionals to improve on from your perspective, and you're also you've also taken this class as an EMT, so you have kind of a foot in both worlds.
And it is the Christmas episode.
Yeah, I'm sorry. I'm not prepared. I'm sorry. Marty came well prepared
I'm
for
not
that.
either.
Ebenezer Scrooge's over here.
I'm sorry.
Bah humbug.
I mean, that is an awesome sweatshirt.
I feel like Nephew Fred.
So how are we doing?
Great.
Good.
How are you doing?
Good. Yeah.
So Victor, do you want to talk about your misadventures over the last few weeks?
Yeah. Ironically, when we were testing out of abdominal pain, I started to experience abdominal pain.
Mm-hmm.
And it was a Monday morning. It was the week we were off for break, so not much of a break for me. And it was, as a healthcare provider, you go through some medical, condition or illness, and do your best as to see what you can do, what's in your control. Can I deal with this on my own? And it's a pain that Justine or myself has never seen before. And the second day, she's like, you should go today. And I'm like, I think I can deal with it on my own, as I'm wincing. And it got to the point where the over-the-counter meds were making things worse. So things like Gas-X and Dulcolax, I was like, I need to pass this on my own. And all it did was made my intestines wring out like a towel, and nothing was passing.
Yeah, you were saying this too shall pass, but it did not pass.
Thy will be done. I would self-induce vomit because that would ease the abdominal pain, and continue to not pass anything. And I submitted to the process, and I agreed with Justine that I should go to the ER. So I went to the ER Wednesday morning, and maybe only took 30 minutes to get checked in through the waiting room, and morphine helped significantly. And then the abdominal CT showed an infected section of the small intestine, and they were telling me about a condition called Meckel's diverticulum, something that I was born with, a little pouch that is attached to the small intestine, and it got filled, and that obstruction dislodged and got obstructed somewhere else and was backing everything else up. And surgery was pretty much the only resolution, and if I came any later, it might have perforated, similar to appendicitis. So surgery was 2 hours long, probably the smoothest part of the process. The day after surgery, I was in better spirits and energy than expected. Despite that, I did not get out of bed. They want you to start moving.
I'd be in high spirits too if I didn't have to get out of bed.
Yeah, and I was on morphine pushes
I was
every
feeling
few
okay.
hours.
You got to do morphine and lay in bed.
I was like, bring out
That's
all
every
the...
grunge rocker's dream.
People wanted to come visit. I was like, check it, I'm okay, guys. I'm like on the mend. And then the next 3 days, I was like in a slump because no energy from no food, and they want you to walk around to wake the bowels up, and the bowels did not wake up. And on day 3, the NG tube showed coffee ground emesis in the suction canister as well, and they then made the decision to remove the NG tube, and it stings the nostrils as the stomach acid, that hydrochloric acid, comes back up through the nose. Cleared in 30 seconds, and then I'm on a water ice chip diet, and then clear liquids, and then they're always asking, like, are you nauseous? Are you are the bowels waking up? And still nothing yet, but we continue to proceed, and then first meal, like the first sips of water were great, and then juice, I had cranberry juice the next day. Perfect. And then tilapia and mashed potatoes on day 3. That was amazing.
Hospital tilapia.
I would have never thought
Brave.
like hospital food. I'm like looking forward to it. And this is something like you have to like order for yourself. Like if you're able to. My nurse ordered like the all liquid diet. So like the entree of the all liquid diet was like chicken broth. I'm like that actually hit the spot. So there's a saying of like, the healthy man wants 1,000 things and the sick man just wants one thing. So it definitely maintains perspective when you come out of it, and just like not losing that perspective once you're back on your feet.
Yeah.
Yeah.
Yeah. Every day I texted you, your answer was on the mend. I'm like, how you feeling today, buddy? On the mend. I wanted to say 1 to 10.
Yeah.
How are you?
Right. No, I'm better, a lot better, 95%. I'm just like, I'm on light duty until January 9th, essentially. And after the doctor, this is like a conversation we were having when she removed my staples. And in my head, I'm like, I already broke this rule. I did a Costco run. When I came back to class, no more water, like the fridges were depleted, right? And I was like, I got to get my cases of water. I got to stock the fridges. And I made sure to use my legs, not my core. So but I definitely, like, she's like, no sweeping, no bending over. You're limited at 10 pounds. And I'm like, I think I broke all these rules already. So yeah, that's a little recap on the last couple weeks for me. But how was Thanksgiving for you guys?
It was good.
Yeah.
It was good. Family time, me, my wife, my kids went over to a cousin's house. And then my mom likes to host holidays, and she was a little peeved that she didn't get to host Thanksgiving because it was at my cousin. So we had Thanksgiving part 2 on Saturday. So we consumed a lot of carbohydrates and turkey. So it was great. It was a nice little bit of time off.
Okay.
Nice.
Ruthie?
Yeah, we had a great time. I actually didn't have to work the night before or the night of Thanksgiving this year,
Nice.
which was so nice.
Was there another holiday that you're working?
I'll be on New Year's Eve.
Okay.
But that's pretty typical. So, yeah, I had my middle brother and his wife were in town, and they're expecting their first kid. So that was special to be able to hang with them during this time. And yeah, we kept it very chill. Did a few holiday things. We went to the illumination at the Arboretum.
Okay.
And walked around, saw the lights there. So it was a good time.
Nice. To give people some perspective as far as what Ruthie means to us, and this is like Ruthie's second time. There's an episode with Mr. John Sanchez a few months ago, but Ruthie, I still vividly remember we were in the Behavioral Sciences
BSB.
building, BSB, this labyrinth of a maze on UIC's campus. And Ruthie would sit next to one of our other instructors, Dan Babiar. Shout out, Dan. You took me to the ER, so appreciate you, Dan. And they became buddy-buddy. Ruthie quickly crushed the class. And was it immediately after when you started helping out with the class?
I was just thinking about this today. I'm pretty sure you invited me back that summer.
Okay.
It was either the summer or the fall after I graduated. And
Yeah.
Because what year was that?
2018.
Okay.
Yeah.
Yeah, so we no longer had the ambulance anymore. And I remember that class, and I remember Dan Babiar, he's not here, but I'm like, man, this kid dresses up every single day.
He does.
I'm like, what does he think this is, Catholic school? And I remember one time it was probably like almost exactly 6 years ago. I'm sitting there and I feel like garbage. I'm super sick. And I'm like, okay, guys, we're done with class today. And Dan comes up after class. He's like, he puts his hand on my shoulder. He's like, I'm real concerned about you. Are you okay? Dan, you're a sweetheart.
Yeah, no,
A well-dressed sweetheart.
Him staying by my side.
Dress shoes always.
In the ER, yeah, dressed to the nines. He definitely got the feeling. It's Dan as usual, but like it's reassuring that he's going to make a great physician one day.
Yeah, for sure.
So yeah, Ruthie came back back then it was volunteer terms. And I guess what was your main motivation for wanting to immediately share some of your experiences back with future students?
I had fun in the class, and I think I knew that coming back to volunteer and help with more future students was going to be fun too. Part of that was how enjoyable you guys made the time, and just what you guys are cool people to be around.
Yeah.
Thank you.
Thanks.
But I think also the summer after I graduated from the EMT class, I got a hospital job, and I knew I was going to be working full time in a hospital, and there was a sense of wanting to stay connected to the EMS roots, and still be able to keep my mind sharp on that, and just to encourage people to keep pursuing careers in EMS.
It's like prior to that, it was kind of unheard of for an EMT, let alone a brand new EMT, to get a tech job. I mean, did you feel that at all, or was there such an opening, like plenty of openings for help?
I think it was like right around that time where we started to see, like people say the shortage was all COVID driven, but we really started to see that shortage then. And that's where a lot of it changed, where you were seeing more EMTs as techs. But you're right, Vic. Like, I remember, like, when we went through EMT school.
Yeah.
I went through EMT school in
It's
2009.
It's a job for medics.
And like, I'm like, and that was the goal, because back then I'm like, I want to be a physician. And, I wasn't really sure I wanted to be a paramedic. And I'm like, becoming a tech might kind of lead me in that direction a little bit more. But I remember there was nothing. I think like Mercy Hospital was like the only place that hired EMTs. And then more of them started to. Some places still won't hire EMTs, like Stroger. You have to be a medic.
So at that time, Ruthie, were you still comparing options of what your next step would have been?
Yeah. So I knew I was pretty sure I wanted to work in a hospital. So I was definitely hoping to get a tech job, and I applied at multiple.
Which is interesting, because you're coming from a completely left field dance experience.
Yeah, performing arts.
Yeah, you were teaching as well. Was that ever a goal to go all in on that stuff, or was there another thing outside of healthcare that you were considering?
Yeah, I envisioned being all in on like dance education, or some sort of arts admin. Was where I had seen myself going before I got interested in the healthcare stuff. And it was always just, with healthcare, it was just, let me try out a little bit and see if it sticks, see if I'm good at it.
Was there anything motivating you to go in that direction in pursuing healthcare versus something else?
Yes. So a huge part of it was just curiosity and fascination with medical stuff.
Okay.
I always thought that was cool.
Did that stem from media or something in your personal life?
Yeah, from a young age, I watched the show ER and always thought it was cool. Nothing super personal. Blessed with a lot of like very healthy family and personal health. But yeah, from that TV show, and then I had multiple friends who were. I had a friend who was an EMT and a ER tech, and then multiple nurse friends, and specifically one who worked overseas in a like a field hospital in a war-torn area. And the stories she shared once she got back from that sort of deployment just like really piqued my interest. And I think that was one of the moments when I started to become super motivated to at least try it out and see if it was a possibility for me.
What was your experience like between nursing school and EMT school? Was it reassuring? Was it reinforcing? Were there aspects of healthcare that you wanted to explore outside of emergency medicine?
Yeah. So both EMT school and nursing school were very reassuring that I was in the right place, because I felt excited about what I was learning, and I enjoyed even the hands-on stuff, especially the hands-on stuff. But emergency medicine, and I would say like critical care. I always thought like ICU nursing was interesting as well. After school, as I go on, I get more interested in kind of community or primary health, especially in kind of underserved communities. I don't see myself doing that now, but maybe somewhere down the line.
Is it because you see some of that in the ER anyway?
Yeah, part of it is seeing how broken our system is and how people use the ER for primary care, and how just difficult that is. And so I think it'd be really cool to work with people in a clinic situation where they're getting the care they need through a primary care provider, and they're not ending up in emergent situations, life-threatening situations, because they have their medications and they're getting regular checkups and they know how to take care of themselves in between checkups.
Facilitate a little more proactive approach than just reacting all the time. Yeah. Because, I mean, like in emergency medicine, EMS, that's all we are really doing is reacting, and, there's always this follow up with your, PCP to get this, chronic medical issue under control, so this doesn't happen again. And we deal with like kind of the manifestation of this chronic disease doing whatever it's going to do to the body. And it's not that it's all preventable, somebody, no matter what sort of lifestyle they adopt and, treatment plan they adopt, they can still have that stroke, they can still have that heart attack. But like when you look at like someone coming into the emergency department with diabetic ketoacidosis and they've had diabetes for 20 years and they know how to treat themselves, but they just don't for one reason or another. So there is a lot of just being reactive, I would say. And it's a whole different type of healthcare than...
That can be frustrating though, right? When
I mean, I think it is, but I think it's kind of the nature of what we do. You put out fires, you don't like change the fire code, right? So it's just like, if somebody followed this treatment plan, maybe they wouldn't be here today. But that's what we're kind of in the business of. We're not like as crazy as it sounds, like, even though we're dealing with the public, we're really not public health focused. We're doing a lot of treating these emergent issues because people haven't been proactive. I mean, that's a lot of what we do.
Do you oftentimes see people get better in the ER and just get discharged? Like, I wonder what the ratio is versus like admitting versus discharge.
Yeah. I think it totally depends on where you work, for one thing. And it's different day to day. I mean, I can go through a shift where it seems like 75-80% of my patients are admitted. And then I can go through a shift where potentially I'm in the fast track area, or I just happen to get a bunch of patients who have complaints that are somewhat easily fixed, and they get sent home. But I feel like at my facility, at least, the doctors lean towards admitting more than not, especially when people have comorbid issues they're coming in with.
Without giving away the place of where you work, you did start as a tech. I mean, how valuable was that leading up to helping you make an informed decision on whether or not nursing was the right, step, as well as continuing to work there as a nurse?
Yeah. Being a tech made all the difference.
How many years was it?
I was a tech for 4 years.
Yeah.
Before I started as a nurse, almost to the day.
Did you feel, was that the ideal amount of time? Or did you feel like a little complacent? Were you still growing as a tech in year 4?
I think I was still growing. I think if I had gone, too much longer than that, I might have settled a a little bit back. Part of what helped me not be complacent was working here, right? Being involved in education. But also I was in nursing school or taking prereqs for nursing school almost those entire 4 years.
Right.
So I was pretty
You're still
active
growing,
and
yeah.
learning like constantly. But yeah, I mean, when I started as a tech, I thought I wanted to be a PA. Like I had a super different perspective.
Like everybody that takes the EMT class wants to be. Why are you here? I want to be.
How many
PA.
new hires that are tech are like, I'm doing this for PA school? Okay.
Almost 100% of them.
We'll see.
I actually had an ER turn me away when I applied to be a tech at their facility because they knew I wanted to be a PA and they thought that would make me leave too quickly.
Yeah.
Sure.
But I think it's a great motivation. I mean, if you're pre-PA, pre-paramedic,
it's great to have goals. Yeah.
pre-MD, it's great. It should make you a better learner,
Do
hopefully.
you think that, if you look at some of your coworkers, everybody has a different path. Do you feel that you are a little more maybe empathetic towards PAs? We're asking these guys to do a lot here versus maybe some of your coworkers who didn't really have that same experience in, being an EMT, a tech, and then a nurse. Do you feel like you work better with techs compared to some of your peers or coworkers?
Rephrase the question. So like people, are you trying to compare her experience with people that never were techs?
No, I'm compared to other nurses. Because you were a tech, do you feel that you can work more closely with the techs in maybe a more professional way? Like you have less frustrations with coworkers that are techs versus maybe your fellow nurses who have never had those similar experiences. Because I know, like when I was a tech, I hated it. I thought it's the worst job I've ever had. I've gone on record saying that it was brutal. It's brutal because, and again, I was told that this, and I was talking to Victor about this today, that this might be a sign of ADHD, but I hated when somebody I was educated. I had a master's degree at the time, and then I had nurses, educated as well, but just had a bachelor's degree, talk down to me like I'm a moron. And it frustrated me so much. Do you see any of that? And do you feel that you have more empathy for people who have less training than you do in that same clinical environment versus maybe some of your peers?
Yeah, I would definitely say that my experience as a tech has made me more empathetic to our techs in my department. There's a very personal connection with some of them who I worked alongside. But I think at the end of the day, I know what it was like to be a tech. In a lot of ways, I still think of myself that way. It's like now I can just do all the extra stuff.
Are they still saying Ruthie, go get a 12 lead on this person?
I offer. If all the techs are busy, I'm like, I got the EKG. It's fine. So I would say it makes me more empathetic to what they're going through. So being an ER tech was probably my favorite job, but it was the hardest.
Yeah. I was not in the ER. I was in an urgent care.
So a lot of your frustration probably came from short-staffed, issues and having to
and coworkers,
grunt a lot of the work.
Not fellow techs, but
Well, I think your average tech doesn't have a master's degree, right? So it's easy to assume your level of education, how much you know or don't know, and it's just like.
But I think that goes to a greater point that you're not any better than somebody.
No.
And you're not above any line of work. And similar to the field, the EMS field, you see it all the time. Paramedics look at an EMT and look down on them because they're a paramedic. This person is an EMT, and that's ridiculous. And most of my 911 experience as a paramedic, most of my partners have been EMTs. They haven't been other paramedics. And I always, and I call it out, because if I see a paramedic, especially a new paramedic, talking down to an EMT because they're a paramedic now, I put them in their place because it's inappropriate. And I think that it's something that, Victor says all the time to our graduates, like, stay humble and, pass the torch, help teach people rather than kind of cut them down because you know how to read a EKG, probably pretty shittily, but you can read an EKG. I just don't, I never really appreciated or kind of.
I wonder why that is. Like why they forget that they were once EMTs.
I think it's insecurity. I think it's a personal
like
issue.
has like this culture of like you are the highest level of care in the pre-hospital setting, right? This like God complex.
Yeah, it's ego.
Yeah,
I mean it's ego. It's that you see it in a lot of professions. Like you see it amongst attorneys, you see it in physicians that once they get to this level, they feel that they are better. So, not all of them. It's small, minority of them, but people do feel better that they are better than people because of the trials and work they put into something.
Well, they haven't experienced enough of life because it'll humble you.
Well, yeah, and you're mortal like I am. It's, but it's interesting, and I think that can I think we could kind of move into kind of our next thing that I want to talk about, which is a little adjacent. So, you started your education in healthcare as a EMS provider, though you haven't really worked for a fire department. The education that you were given was from that EMS perspective. So how do you think that helps you? And still being tied here to Chicago EMT training, working with EMTs, many of which who want to become paramedics. How do you think that helps you in your current role as an ER nurse?
I think that starting in EMS, having that mindset helps me prioritize as a nurse. I'm always thinking about not just simply ABCs, but really what needs to happen first, second, and what can wait. Mm-hmm. And that's time management kind of goes along right side along that. So I think those are kind of the major takeaways that are always in my mind. I think also coming from learning about EMS first, I appreciate that I think working as a team with pre-hospital care instead of kind of like us versus them, mm-hmm. or like we got to clean up some mess that was brought to us, but kind of seeing it as more of an extension of pre-hospital care and a flow, kind of we all are working together. It's just we're catching the patient in different phases, and we got to bring the patient from
because they might feel that way
A to
too,
B,
right?
B
The
to
pre-hospital providers. I wonder, how do we cultivate an environment where it no longer feels like that?
Yeah, I mean, I think it's
spelling. Is it the handoff, or are there other opportunities?
I think it's also ignorance. I mean, I think it's just not knowing. So like, I'll come in and I'll be like, man, I just gave that report. That nurse was short with me. Mm-hmm. And I get all pissed off. But I'm like, I roll up in the ER. I see how busy they are. Mm-hmm. And it's like, no, they weren't being mean to me. They're super busy. And their reaction is not reflective of anything I did. Mm-hmm. Rather, it's just they're super, super busy. And I think that you do have a lot of people, I would argue most people, who end up in the ER without EMS experience. And their EMS experience is really cultivated by working in that ER. Like that's their experience. So you see such a cultural difference from ER to ER. I mean, being a paramedic that has transported to multiple ERs, there are ERs I hate because the staff there is rude. Like, I'm not going to mention the ER, but hint, hint, it's the one I go to all the time. I will pull into that ER. So in the front door, when you walk in, it's not the charge station. It's a tech sitting there. The charge station is in the back of the ER. Why? So they don't have to talk to us. So we're waiting there. Someone's stroking out. I'm like, okay, guys, hello. They're like, we'll be right with you. And it's, I mean.
So do you actively try to avoid those ERs then if you're actually having...
I can't.
Really?
It's the closest, most appropriate facility.
That's wild.
But then you have other ERs where, let's say I take them to the other hospital we might go to if we have a trauma. Much more...
conducive.
Well, and much more familiar with EMS in that they teach EMS.
Receptive, yeah.
Yeah, the medical director's there. So you don't have that experience. So there's a lack of standardization. UIC. I'll call you out, UIC, because I don't work with you anymore. Horrible hospital for EMS handoff. Not for patient care. Patient care is great, but their process for EMS handoff was horrible. I've heard it has since changed, where you would bring in a patient, regardless of their criticality, you would have to take them to registration, like a registration desk, and you would have to, the paramedic would have to fill out the registration papers on the patient.
This is how many years ago?
Oh, man.
So this is a while ago.
I mean, since I've been there, yeah.
Okay,
Yeah.
I just want to clarify for anyone listening.
And I don't care if it was 2 weeks ago. But, because those were, and again, I'm not trying to create some conspiracy theory, but they were union employees. They had a very designated task that they were supposed to do, and anything else was something extra. So they would give me the registration form and they'd say, fill it out. And I would say, no. I'm like, no, I'm not filling this out.
I remember doing that, yeah.
I'm like, no. I'm like, I don't know any of this information. I'm like, this person's having a stroke. They need to be seen. This person just had a seizure. They're postictal. They're confused. So, again, different culture. They're different kind of standardization. Where you're at now, or kind of in your current work environment, how would you rate kind of the culture between, the ER and EMS?
It's hard to say. I mean, I have no other comparison because I've
Yeah.
only worked at one hospital. But I think in general, very positive
Yeah.
relationships with our EMS providers. I have definitely been the nurse who is a little short and stern with EMS
Okay.
and it's not because I'm pissed at the provider, it's because I'm pissed at my shift, right? And I am actively trying to get better about circling back around before I try to catch a medic before they leave and be like, hey, thanks for bringing them.
Yeah.
Like,
Are
I'm
you
sorry
an
if I was
ECRN?
short with you. Yes. Yeah.
Can you explain a little bit about what an
Nice.
ECRN
Yeah,
is?
good question.
Yeah. So emergency communications registered nurse, I believe is the proper what it stands for. But it means that we take some extra training to learn the SMOs of our region for EMS. And it allows us to answer the radio and communicate with pre-hospital providers over the phone. So we create a little run sheet based on what the report we get from EMS, and we hand that over to charge, and we can kind of identify what sort of care this patient is going to need once they get to the ER, so that we're prepared for what room they need to go to, whether they need to be a code, like everyone's in the room and it's paged throughout the hospital if it's a trauma or a very sick person, or if it's going to more of like a general care area.
And do you make that decision, or is that like really charge who makes that decision? Do you make that decision together?
I would say it's mostly charge. There can be some
you
shared.
hand the report to charge?
Yes, but it's if charge wasn't listening to the call,
Yeah.
like I need to communicate what I heard on the phone, right?
Yeah, you definitely influence their decision of
Yes.
what's going to happen.
Yeah. And then for traumas specifically, because we're a level 1 center, and our trauma surgeons have created specific criteria to activate trauma alert. So
Like minimizing any ambiguity?
yes, so there is
Specific injuries, and yeah.
extrication time, level of intrusion into a vehicle, all those kinds of things, presence of a tourniquet, whatever. So that list is like right by the radio. So that one's pretty much cut and dry. Like you either check yes or no.
And do you feel like they do a good job saying like, this is a trauma alert, this is a STEMI alert, this is a stroke alert?
Yeah.
Good.
That's typically the first thing out of the mouth for EMS providers on the radio, which is extremely helpful.
Yeah, I think one thing that the textbook doesn't reflect, and I don't know, I mean, everywhere I've worked, it's been this way. But we talk about like medical direction, like calling for online medical direction. And there have been occurrences where, you know, I'm just talking to the ECRN. They're not really asking the attending. So do you feel like there is, do you feel like you have a degree of autonomy, or do you generally like try to go find an attending doc? Like if someone's like, hey, you know, we have this bad asthmatic, should we give like mag to this patient? Because that's like usually they call that like you have to call the base station. Are you for something like that? Or if they give a report and they're like, yeah, our patient's wheezing, you're like, did you give, you know, a nebulizer? Did you give albuterol or Atrovent? They're like, no. Like, do you say, well, give it, or do you have to find like an attending to give that direction?
No, we are, as ECRNs, we're allowed to give that medical direction without the presence of an attending. I'm a newer ECRN, so if I was unsure about anything I hear over the radio, I would either find a more experienced ECRN or an attending to help me out in providing that support to EMS over the radio. But yeah, we're allowed to say, yep, you need to give this if you haven't already.
Because I don't know if you've ever, like, in your education of EMT or paramedic, and I know teaching EMT and paramedic, there's nothing in the text that really describes that medical direction won't be given by a medical director.
No, I mean, if I were to assume you have the SMOs in front of you, and so if it's kind of written, as we do too, right? So if it's there, these physicians have put it into, you know, a book essentially.
Yeah.
Yep.
And if you had any, you know, ambiguity, then you would ask.
Yeah.
Yeah.
The only times we absolutely have to have an attending
Time of death.
Field
is
termination.
time of death, field termination of resuscitation, and then refusals.
Okay.
So, and in that case, I mean, EMS will be asking for the provider's name. And
If there was a refusal called in, and it's like, hey, we got called out to a, you know, MVC, nobody's injured, no airbag deployment, we still get a refusal. Do you say, okay, like no drugs or alcohol, no, you know, they understand the risks, or do you get a medical director or a doctor and they talk to the
we get a doctor and they
wow.
speak to the paramedic.
Okay.
It's different from the region that I worked in.
Yeah,
Yep.
I mean,
It's
well,
different.
Region 11, you don't call anything in.
Well, Region 8. Region 8.
Yeah, Region 8, you call.
I don't remember.
Everything.
You call, but I don't remember a physician ever being on the phone.
I mean, I've gotten calling in refusals in Region 8, like for complete BS. Like, father has dementia, called 911 on his daughter for screaming, and said she needed a psych eval. We come on scene, everything's calm. Daughter's refusing to go to the ER. Does the dad feel safe at home? I'm like, I don't know. I'm like, what does that have to do with anything?
Yeah.
Yeah, that's always a sticky wicket, like kind of refusals. And if I had to guess as to what the future holds, I would guess that in the future, EMS providers are going to be a little more autonomous, be able to be a little more autonomous with that.
Really? I think it all stems from covering your ass. And
It does,
And the
but-
system wants to cover their ass.
It does, but like you look at other providers, and paramedics are different than nurses. And I don't mean in the sense of like they have more skills. That's not what I'm getting at, or more knowledge, but they have a different role. So they're rendering care directly, and there's really no one watching them. They're doing it through a physician.
Yeah.
But they're
still on their own.
They're making these decisions. And actually there's a nationwide push right now to get rid of protocols completely. and make them guidelines. They say this is a guideline to allow that paramedic to make more decisions. And there was like a trial EMS system where they were allowing paramedics to deny transport to an emergency department. Like, one of the frustrations, I don't think like people like truly understand this. Like, we got a call the other day. We took this kid. He was carrying a table down the stairs with his sister. He's 15, should have been in school, wasn't. His sister is like 30. We know her, she's a regular. Carrying this table down the stairs, drops it, cuts his arm, injures himself. We come on scene. Obviously, we're transported him to the ER. There was kind of an issue. Mom wasn't there. You know, sister's not legal guardian, but like threat of life to limb. I mean, he wanted to go. Mom was contacted. She wanted to go. Took him to the ER. We get a call back, or we're not on the run. We're still like on the way to the hospital, transferring care. We get a call back to that residence for the sister, who is now intoxicated. And it's like, and she was. I mean, I wasn't there, but my the fire crew was there, and then they had to call in a mutual aid ambulance. She is intoxicated. She's in her house. She's an adult. But as soon as EMS gets in there, they have to drag her against her will into the hospital for nothing.
Who made the call?
County was there still, the county police, and they were still there, and they're like, this lady's drunk. It's like, who cares?
Oh my gosh.
Yeah.
But now we have to take this person to the hospital who has no emergency.
We've gotten that question in class before of like, what if you had a disagreement with someone in a bar and you call on them?
Medical direction. I mean, correct me if I'm wrong, Ruthie. As soon as you admit that there is possible alcohol intoxication.
Region 8 is different.
Well, at Region 8, it's pretty similar to Region 7 in terms of their alcohol kind of feelings. But like, if this person's drunk and there's some sort of injury,
no injury.
No one's going to approve that refusal, because they're not going to feel comfortable saying they refuse. Like, even in situations when things are dangerous, and we could talk about this in a moment, where EMS says like, we can't safely get this person in the emergency department. They're going to say, we understand it is unsafe, keep safe, but this is not a refusal. We are not granting you a refusal.
Right.
So where they're not, because that person can't refuse because they're confused or whatever it might be, but they're very refusal decisions. And one of the things I tell to my patients where I know like they're refusing, but it's not going to matter, I tell them it's not my decision. I need to call it in. It's the hospital's decision. Mm-hmm. So.
Yeah, that's wild.
Yeah, and I
think with 8 though, I think the patient's ANO4.
No.
ANO4, and there's a checklist that you have to run through.
Not anymore.
They got rid of that?
I'm Region 8. If they take a sip of alcohol, they have to go to the hospital.
I wonder why they backpedaled. Because that was the case in 2015.
Not in 2024, year of our Lord 2024. If you have any booze in your system, you're going to the hospital.
Wow.
And it's one of the most frustrating things, I would say, for our nursing staff and just for our ER staff in general, is having patients who are intoxicated, but we're in a safe environment, not any like known risk of injury, but are brought in either by EMS or by family, basically because like maybe someone else doesn't want to deal with them.
Yeah, exactly.
And sometimes even police too. And it can be really frustrating because if that person, and it's different physician to physician, but some doctors will say, if you can get a sober ride home, I don't need to keep you here, but you need to show me that you have a sober ride. So someone has to come up and see the physician face to face and take them home.
Which makes sense. It's practical.
Yeah. But if someone was already trying to
And that was
get
one
you
of the
out their
criteria
hair,
with 8.
Yeah, not anymore.
So it's like ruling out, diabetic emergency, head traumas, seizure, syncope.
Yeah, now any drugs or alcohol, they have to go.
I've never would have thought they would have approved it for edibles for sure. But at the time, a glass of wine, a beer, and you had someone to take you
I
home.
would be much more comfortable refusing it with cannabis than alcohol.
And the hard part is like, how do we know that was just cannabis?
Well, how do you know it's just alcohol? And how do you know? It's all about liability.
Yeah.
I mean, that's all it is. But have you run into that where you have someone calling in a refusal, but it's not really a refusal. It's just this person doesn't meet the criteria to refuse care, and but it's unsafe for them to bring them in. Have you had any?
At what point would it be unsafe to bring them in?
Well, now police assistance with EMS transport has reduced quite a bit. So like if we have like a patient who's like, let's say intoxicated, and he's gonna fight us, well, I'm not getting in a fight with anybody. And if police won't help us, we call that in. We say this person's refusing to go, but they're intoxicated. They'll say, we are not granting you a refusal, but we understand why you cannot transport this person.
Yeah.
So
I've not personally been on any calls.
What ends up happening then? Do they go to the?
No, they don't transport them, but it's just documented.
They don't go with the cops either.
No, cops won't take people anymore.
Oh.
Okay, policing, and I mean, I'm going to piss a lot of people off by saying this, and but from my experience, the police don't assist us as much as they used to, and it's because of the political environment amongst other things. But like we've had patients who are like downright violent, and what they do is they push them into the back of the ambulance and close the doors. And they start biting and kicking and punching us. And like, I'll open the other door and say, run off. I'm not fighting you. But it is, I mean, it's one of the big topics in EMS right now is this person doesn't need to go to the hospital. So why are we having them go to the hospital? We already have an overtaxed system as it is.
Well, it's like what happens if this person ends up dying, right? So it's that liability issue, and there was an opportunity for them to go to the hospital, right?
Yeah,
right.
But then you have to consider contributing negligence. Is it
on their behalf?
Does that have anything to do with us? I don't know. It's a tough question.
Well, it sounds like at the moment the whole back and forth communication with ECRNs is the appropriate way. It's like, I'm not granting you a refusal, but I understand.
Yeah, well, I think they kind of had to work through some of that verbiage, because I think first they were saying is we cannot grant you the refusal. And it's just like, well, if you say that, some new EMT or paramedic will be like, they said we have to bring them in. So I think they have to say, like, we understand it's not safe to bring this person in, and your safety is the greatest priority, but this doesn't meet a criteria for a refusal. So regardless of whether or not this person gets transported.
The hospital's protecting their ass, right?
Yeah, they have deeper pockets. And they have, more lawyers. So kind of to shift back to what we were kind of talking about earlier, with your kind of experience in going through an EMT program and working in the ER, is there anything because you know what we do, you teach us. So is there anything that you kind of get frustrated by? The EMS brings in a patient. Are there like situations where like, come on guys, whether that's like, this should have been ALS, or, you didn't even try starting an IV. Is there anything that it maybe is a pet peeve of yours when it comes to something EMS does, and how do you think that can be improved upon?
Well, I want to say, like I said before, I think we work with great EMS providers, so it's pretty rare that I have issues. But we see a lot of patients and a lot of ambulances, so it does happen. So you named two of them that definitely come to mind. People who come in BLS who should be ALS. Many times it's not always. That's not even the EMS provider's fault. That may just be an issue with dispatch or
like transport,
availability.
They sent a BLS unit. Okay.
Yeah. So totally not on them. But there are times when the ambulance has capability for ALS and they have only delivered BLS care for like a cardiac patient, and that's that can be frustrating. No attempt at an IV in a cardiac or ALS patient. Definitely a big frustration. And I would say when I get an altered patient and I don't receive like a sense of what is baseline for this person, and I like 99% of the time our EMS providers are great at identifying that, but when that doesn't happen, it can be really, really frustrating because it's going to take me a long time to figure out, make phone calls or dig through the chart.
And
me and my
it's
providers.
Like you're not, so your main concern is finding out, and it's a lost teaching opportunity.
Yeah.
It's just like, it's like, why didn't you guys get this? And you could have gotten this, but your priority is to like with the patient.
Yeah. My big AMS thing that I say is always 3 questions. Like, is this normal presentation? Like, so I teach students that like, don't look at this patient through any filter except for your own. Don't like, oh, this is their medical history. They're old. This is a nursing home. Of course they're altered. I say, like, if a patient ever appears to be altered, ask the question to someone who knows somebody, is this normal? Are they acting normally? And then I say, you follow up that question. If the answer to that question is no, this is abnormal, I follow up that question with, what is abnormal? I mean, they might say, they're crabby today. Well, that's not AMS. And then I say, when was the last time they were normal? So I think kind of like another question you can ask is like, what were they doing when they started to act abnormal? But I really think that those questions, like you said, are extremely important. I remember I brought in a patient one time, and this is kind of, paints the picture of sometimes why this might happen when we're not getting this information. We were called from the hospital to a residence, which is like probably a 10-minute drive. And we had a BLS crew there, just an engine, they can't transport. And they're calling me on the phone, not over the radio. They say ETA on the radio. Whenever someone asks for an ETA, you're like, shit. They call me on the phone. They're like, I don't think this lady's breathing. I'm like, well, you need to ventilate her. I'm like, does she have a pulse? Yeah. So we get there real quick. They already have her on the stair chair when they're bringing her out. So I didn't ask shit. We threw her in the back of the ambulance. We intubated her. So it was, extreme hypothyroidism is what ended up causing it, and like a series of strokes. But like I get to the ER, they're like, what's her name? I'm like, I am not sure. They're like, what's her date of birth? I'm like, I do not know. They're like, is family coming? I'm like, I think so. So like, I'm like, I felt horrible. And I felt horrible for the patient, not just the, the nursing staff that now had to be detectives. Yeah. So I think that like,
that comes with time though, right? It's so overwhelming to just deal with the ABCs of a patient and you forget about all the demographic information.
Which is important though, right? Because you can't necessarily, like you said, you can't establish a baseline. Yeah. So, but yeah, I think I tell people all the time, I ALS everything. And I don't get frustrated when people don't. But like if I'm in charge that day, people roll their eyes at me. But I'm like ALSing everything because for me, why not? I mean, if it's like someone stubbed their toe or, someone is like depressed, I'm not ALSing that. But any like legitimate medical
I think the longer
complaint.
you do this, you will eventually have patients with such ambiguous signs and symptoms that can stem from cardiac related issues.
Yeah.
Oh, yeah.
But my big thing is like, how much more work is it? The hardest thing about being a paramedic is writing that report. That is the hardest. Everything else is easy.
Yeah.
That's the hardest part. And the report's not really much different. So I'll try to start an IV. And I think that people, like you say, no IV attempt.
I think they probably use the excuse of like, we're so close to the hospital.
Yeah.
Yeah. Which is
Then why did you do that? Like, why did you become a? I don't know. It's just like, and then you complain about being an overglorified Uber driver. It's just like, you're a medic. Do your medic things.
Yeah.
I'll say one other frustration, and I mean, this only happened one time in my experience, and I've only been a nurse for 2 years, so kind of limited here. But one time, and I'm not going to blame it on. I'm not sure if it was totally EMS's like fault, but EMS gave report to my tech who was in the room, and I had not gotten to the room yet, and they didn't wait for a nurse to come in. And at our facility, they are 100% of the time need to give report to a nurse.
The law states they do.
Yes.
Even if that tech is a paramedic,
Yeah.
they are not functioning as a paramedic. They're functioning as a tech.
Yeah.
So.
And I didn't even catch the crew, so I talked to my tech and I just said, please don't ever let that happen again. Like, I'm not blaming you. You did what you thought you had to do. Maybe you thought they had already talked to the nurse, but like, please get a nurse next time, because I mean, even the techs I trust like the most, like I would never want them to
be liable.
Be liable or to leave. Yeah. And at the end of the day, it's my fault. Right. And so, and I need to take care of this person. So I need to make sure that I can ask questions to the crew.
And you guys are color coded. I mean,
we sure are.
So you should know what somebody is.
Yeah. Exactly.
Yeah. Is there anything that you think EMS does that makes your job a whole lot easier? Is there ever like a situation where you're like, oh man, thank God this person didn't walk in themselves? Like, is there ever a situation like where you would prefer like EMS to bring a patient in versus a walk-in? And, what about that is, I guess, makes your job easier? Or, not necessarily even that, just how do you see that improving patient outcomes?
So it's probably the most obvious when we have true emergencies, so code type situations with trauma patients. EMS brings them in and they're already pretty much exposed. Maybe there's a little bit of underwear on or something, but at least that part is done, and we can very quickly identify injuries versus when we get walk-in GSW, right? You got someone complaining about their arm. They won't let us take off their pants, and it's like, oh, they have 3 other holes in their lower body, right, that they didn't know about because of distracting injury. So there's that, and then I would say super thankful when EMS can provide a good story, give me a good idea of the narrative that built up to this moment. I had a patient the other night who was choking when unresponsive, cardiac arrest. They got him back, but the EMS was able to provide a really good picture of estimated downtime and kind of everything that led up to that point. So very, very helpful. Last known normal for our stroke patients or any neurological patients.
So a lot of time sensitive issues.
Yeah, time sensitive issues. And just like good cardiac monitoring, being able to tell me what rhythm they've seen on the monitor, and an idea of where the vital signs have been at. Have pressures been all over the place, or have they been steadily low? Have they been steadily high?
Because we work with a lot of the same people, and EMS provider wise, and I've done a lot of education, to EMS providers. And one thing I am noticing that, and not to critique your older paramedics, but one thing I've been noticing just personally is it used to be becoming a paramedic was a pathway to becoming a firefighter. But now you see there are a lot of people who are just becoming firefighters to become paramedics, that they want to work on a fire department, do emergency response, but just do the paramedic thing. And because of that, you're noticing they actually care what the rhythm is. They can, I remember when I was doing my internship as a paramedic, they'd say, it's not normal. The rhythm's not normal, but we don't know what it is. But that's not the case anymore. I think people are taking this role as an EMS provider seriously, where it used to be, I don't want to say an afterthought, but it used to be something they do sometimes. Like, I'm a firefighter and sometimes I act as a paramedic, but really embracing their professional identity as a paramedic. Also a firefighter, but really embracing and caring about what they do. And I don't think that is necessarily something maybe we see nationwide, where, here in, or anybody listening who's not from Chicago land or Chicago, EMS and fire is integrated. There are some situations where it's not, but largely it is. Other parts of the country, they're not integrated. So if you want to be a paramedic, you're just that's what you're doing. But here a lot of them are dual role. Is there anything that you think, or a few things you think maybe that we could do better with as EMS providers that can make a big difference in patient outcomes? Something that might be something simple for us to adjust or do that can make a difference in the end?
I would say the handoff time period is really crucial, because that's all I get to talk to you as a provider, right? So taking the extra 30 seconds to give me a little more information. I know we're both in a rush and we both have to go our separate ways. But telling me anything pertinent to the patient's situation, any extra history, or if you know that family's coming even, or whoever was on scene, really, really appreciate that.
It's got to be easier, though, especially if it's a busy ER, that you get to see the same medics over and over again, dropping off different patients.
Yeah.
Or is it such a large ER that you don't get that kind of feeling?
I definitely recognize people. I don't have...
You're not on a name-by-name basis?
Not with most. Not with most of my EMS providers, which I would like to get better at. But there are definitely people you recognize because they bring you, 5-10 patients throughout the night. So I'm like, hey, how you guys doing? I think just treating each other like human beings, right? We're all trying to do our job. No one's above or beneath anyone.
Which is a lesson that everybody needs to learn.
Yeah.
I mean, 2 years into nursing, do you feel like you made the right decision? Are you happy with where you're at? There's no regret as to not pursuing PA?
Absolutely. Yeah. I have no regrets in
because
pursuing nursing.
we have students on the fence as well. So it's, I think it's reassuring to hear that.
Yeah. I hardly work with PAs. I work with NPs, physicians. So I have a very, a kind of a bias towards that probably led me to where I'm at. But yeah, I love being a nurse. I love the work-life balance it allows me.
Is that something you always prioritize or something you grew into prioritizing?
I think it's always been a priority. But if anything, I think in different specialties of healthcare, work-life balance can be more or less important, and probably based on the individual as well. But the longer I work,
how specialized do you want to get?
Yeah, and how taxing is your specialty on you as a person? So I've learned that working in the ER, while I love it, it is extremely taxing on me, mentally, physically, emotionally, spiritually. It like puts me through the ringer a lot. Especially now I'm doing sexual assault nurse examinations.
So you took the SANE course?
Mm-hmm.
Did you take the most recent one?
Yeah, I mean, I finished last May.
Oh, okay.
So
they just had one a few weeks ago.
Oh, okay, yeah.
That we could have a whole comment on that.
Yeah.
And the statistics of how many rape tests are not tested at all. Like it's.
What do you mean? So you take this? You get samples and they're not tested?
They just end up on a shelf.
What?
And the whole thing with SANE. So they passed SANE's a specialized nurse who can do this examination, this test. There were hospitals that had no SANE nurses, and they didn't build it into protocols to transport people to these SANE centers. It was a disaster. But like my wife, she's an attorney, and she talks about how like these kits, like they were being done, but no evidence, they can't be admissible as evidence because they weren't collected by a SANE nurse. So it's, I mean, that we could have a whole discussion on that. But
how did they collect it? Is there a tedious process to collecting samples, or right? So like, how does someone without that training collect it?
So the way it's been at my facility, so the goal for Illinois is to have every nurse be basically a SANE nurse at some point in the future. We're a long way away from that. But what would happen in my facility if there was no SANE available, it lies to like the most experienced person. So you get a experienced nurse, and basically they just crack open the kit and they have to follow the directions as best they can. Now we have a lot of, in case that that's very rare in my department, that really doesn't happen anymore because we have on-call providers, and on every shift we have a SANE nurse, at least one, if not multiple. But our SANE coordinator also has a lot of, there's an area of the department where there's a lot of resource material. There's like binders that literally can walk you through the process. So if you're unfamiliar, you can get through and do it. But yeah, I mean, what a shame to go through a horrific experience, to go through an invasive examination for nothing to be thrown out legally. Yeah.
Yeah, that's tough. Well, yeah, and I think these are like these things that just the general public doesn't know.
No,
they don't know that, and they probably should. Very, very, I guess a very evolving piece of healthcare is just this.
Well, even with that, I wonder if there's anything on the medics' behalf that they could be doing.
Well, there is. I mean, we
like bagging. Like,
well, don't do anything.
Yeah,
one of the things that they say in like the text is like, do not, and this is a quote. Do not let your patient bathe or comb. But that's ridiculous. You can't. You're not saying, hey, you just went through this. Now you're going to listen to me. Oof. You cannot shower. You cannot change your clothes. You cannot. No. You want to give them an informed, you know, and they might not be in the mindset where you can really give them something, really informed piece of information and they can make a decision. But you want to tell them, hey, just to let you know, if you wash yourself, if you change your clothes, this might affect our ability to collect evidence that might be used to prosecute the person that did this to you. But yeah. Anything else about Satan you want to ask?
No, that was pretty good. I mean, it was a long training though, right?
Yeah, it's about a 3-4 month process between in person and my didactic training was online. I think there's various combinations where people are doing some stuff online, more stuff in person.
And you feel like that was a good pace? Like you wouldn't do it justice if you tried to shorten that?
No, I think it's good that it's a good length of time. The 41-hour didactic part that I did online had to be completed within 12 weeks from when you start it. Mm-hmm. So it keeps you on a pretty decent pace. Mm-hmm. So you can't like start something and then sleep on it for a year and then finish it, a year later. What actually took a while was kind of the more practical hands-on experience, because you don't always get the opportunity to do certain skills every shift you work. And
you're with a preceptor too?
Yes. So I had to do like pelvic speculum exams. So I would do those with a provider, higher level provider, as kind of my preceptor. And then you do a few sane examinations with a preceptor.
This is so random, but like, when was the last time you impressed yourself?
As a nurse?
She got that IV in the foot.
Like you maybe something novel, something new, like you felt like you elevated to the next level in some capacity.
She did a cartwheel yesterday. She was really proud of it.
No, I don't know. I don't think about it that way. I'm happy with myself if I feel like I got everyone where they needed to be. As silly as that sounds.
Yeah, I mean, I kind of agree with that sentiment. Personally, and this might be from a kind of a spiritual, kind of background, but like, I think so many people have this main character syndrome that like they're the main character.
Like I'm not asking from the sense of intentionally trying to impress yourself. Just a realization of like, damn, like that was really cool that what I just did.
But I think kind of what Ruthie's saying is just like doing your job every day, is you're making a difference every day.
Consistency is impressive.
Yeah.
Yeah. I think the moments where I'm maybe impressed a little bit with like how far I've come is when I can think back to like my first like 6-9 months as a nurse, and just like the deep pit of anxiety that I would come into work with, like, what the hell am I going to see today? Like, will I be able to handle it? And now it's like, I still get scared shitless sometimes, but like, I in general feel like I know who to ask for help, and I know what to do. Like, I know that we're going to get through this and that it's going to be okay. And so I think that's something cool to look back over time and be like, okay, it's a little bit of confidence growing there. And just feeling like, not sinking below the water, but kind of like treading. Yeah. Which is, it's a good feeling.
You wanted to bring up UnitedHealth?
Yeah. So it's just, I think just in the time that we, decided to shoot this podcast, In terms of real world events, a few weeks ago, former CEO of UnitedHealth, Brian Thompson, was killed on the street by a person who was disgruntled. The story, this individual wrote kind of what the media is calling a manifesto, like he's like some, supervillain from like a Batman comic.
He's been compared to the Unabomber, I believe.
Yeah, well, the Unabomber didn't care about innocent people. And not condoning murder, first and foremost. Murder is never the answer, and never really in my opinion, the choice to make. But this individual, Luigi, wrote about how his mother suffered from crippling chronic pain. I don't know if she had like spinal stenosis or what it might be, but her whole, since she was in her 30s, she would have to crawl on her hands and knees to use the bathroom, multiple surgeries, and dealt with insurance companies, instead of being a group that helped facilitate wellness, being a roadblock, not approving care, and then this individual, it seems, I'm not clear on 100% of the details, but it seems that he has something similar to what his mom had, where he had to get neck surgery, and he also suffers from chronic pain, and he's being, has claims denied to receive care. And this kind of brings up a kind of like this thought that, like, why are we letting banks decide what sort of care should be rendered for people? And I find this personally frustrating working in
insurance
healthcare.
Companies?
Yeah, which are banks. That's what they are. Why are they deciding? Like they're calling Brian Thompson a CEO of a healthcare organization. It's a bank. And, it's about profiteering off of collecting insurance deductibles, and approving less and less.
Yeah, this is one of those examples where we tell our pre-med students that they're entering a very bureaucratic industry.
And as time goes on, I don't mean to sound like RFK here, but like as time goes on, it is kind of alarming how we see this corporatizing, this corporizing, all these hospitals going corporate. And we see that all the funding for all research is kind of backed up by these big businesses. And like we are working in a industry that is profiteering off of illness. And, is it time for private insurance to go away?
And aren't a lot of hospitals nonprofits?
They're yes, hospitals themselves I think are nonprofits, but I think the hospital groups, but
yeah.
You also, the reason they don't have an endowment, they pay out bonuses, so there goes their profit. But it scares me because, like, Ruthie, you bring up a point, and it's something that, like, I notice where because there is a lack of coverage, a lack of knowledge, people are using us as their PCPs. I have people who call 911 and they're like, my blood pressure's high. I'm like, okay, I'll take you to the emergency department. They're going to discharge you and you're going to get a bill. And it's this cycle where I really see that our healthcare system, if it hasn't collapsed already, it's on the verge of it. waiting times in the ER, people who can't pay their medical bills. I think it is kind of like one of these situations where we really, as
it's a negative cycle, and I think you have to choose your battles of what you want to tackle. Do you want to tackle legislation? Do you want to tackle it through public health? Do you want to, and I think EMS has a very unique position to do a little of everything.
Yeah.
But it's picking your battles.
Yeah,
right?
I think so. One thing that this isn't a political podcast, but one thing that just bothers me so much is that supporting private health insurance like Blue Cross Blue Shield, UnitedHealth, Aetna, being in support of these companies is the patriotic thing to do. That you are some, left-wing communist crazy person for entertaining the idea of socialized healthcare or universal healthcare, and that just bugs me so much.
So what category do you fall in if you don't subscribe to healthcare? Because that was me for the longest time.
A moron. Just kidding.
I told Marty this before we started recording, but I got very lucky. My week-long hospital bill came out to 5 Gs.
You're kidding.
Because the hospital subsidized 80% for uninsured individuals.
Even then, that's a great scenario, right?
Yeah, very lucky.
But you look at these people and I guess maybe I'm becoming radicalized because my mom has spinal stenosis and insurance provider, UnitedHealth. She has documented spinal stenosis. She gets a cortisone shot. She can get one every 3 months or 4 months. And she's up for a shot. And they're like, UnitedHealth says, you need to get another MRI. She's like, I got an MRI 4 months ago. Right. You need to get another one. Okay, gets another MRI. Has to pay the deductible of that MRI. And then they say, okay, you need to fax over the MRI. It was sent digitally. We needed fax too. Then we need a mail copy of the MRI. And then, oh, sorry, your request for the shot has lapsed, so you need to request it again.
Good Lord.
And it's this stupid game, and it's not. I mean, you read stories, and again, this is on social media, but you read stories of these doctors who are trying to prescribe Zofran to a kid with cancer, and UnitedHealthcare denying that. I mean,
yeah, I saw that letter.
Yeah, and again, it's I'm not condoning murder. Murder is wrong. But when you have all the ingredients to bake a cake mixed together, you're going to get a cake. And I think, it's, you see these people with chronic pain and, to live every day of their life in pain and not having a solution, and just being in you see people with cancer, end of life, childhood cancer, where the insurance company is something we have to worry about.
Right.
Our parents didn't have to worry about that. This is a new, and it started in the 70s, but this is not, it needs to change, because I really do think that once you have insurance companies covering less and less and less, kind of a point you asked earlier, is it even worth it to have insurance anymore? People don't have insurance. When they have a problem, they're going to call 911. They're going to go to the ER, and that's how they're going to receive their care. Now, this 20-hour wait time for the ER is going to be a normal thing. Mm-hmm. I think it's...
So what's the happy middle? Or is the solution socialized healthcare?
Well, if you look into statistics, you look in the data, I mean, we're the only nation that has this private healthcare system, and we're by far not the most healthy country. So I don't know what the middle ground is. Well, the middle ground is insurance companies start paying for, things that people need.
Yeah.
And doctors make decisions. One thing I was thinking about, I'm like, what if instead of private health insurance, you subscribe, and this is kind of like an HMO, but you subscribe directly to a hospital. Like, I'm going to sign up for Loyola Hospital, and that's where I receive all my care, and I pay them $100 a month. I go into Loyola, I get whatever I need. And it would have to be subsidized by the government. But, I think that it's the direction it's heading. And, Ruthie, I would like you to comment on this if you could. The direction that healthcare is heading doesn't seem like a good one. I mean, I have a chronic medical condition. I used to see an endocrinologist every 3 months. Now I can barely see them once a year. Maybe it's
due to
once
cost?
No, due to no availability.
Availability.
Oh, wow.
Yeah.
And it's like, it's just really tough.
Yeah.
Yeah.
It's such a broken
Is that
system.
a concern that a lot of your patients express?
Absolutely.
I have people say, I cannot go to the hospital. I cannot afford it. And what do I say to them? Sir, you're having a heart attack. Don't worry about not paying for it. I mean,
Sign here, refuse here.
The amount of people who have done their diligence to try to follow up with a PCP, but the next appointment they can get with a specialist is 9 months from now.
yeah, a pain doc.
Yeah,
Yeah.
or a neurologist for their migraines or whatever it may be. So they end up right back in the ER, and then they're going to get stat ordered tests, which is great. It'll provide them maybe some answers and some help immediately, but then they're faced with this bill, and I think if there was a way to take out the greediness of the healthcare industry or the insurance industry, and make things cost what they actually
What if insurance
cost.
companies were nonprofits? with that.
Well, they call themselves nonprofits probably, but it's
Things. The charges and the hospital bills, and it doesn't represent what things should actually cost.
No.
and they're
it's
set by the insurance company.
yes, it doesn't make any sense.
I mean, the
$200 for Tylenol.
the hospital subsidizing 80% is just a sign of that too.
yeah.
Well, you could go to I'm type 1 diabetic. I could go to Mexico without insurance and buy a vial of insulin for $16. In this country, with insurance, I'm paying $30 a vial.
Yeah.
I mean, and again, they used to spoon feed us this bullshit that you want universal health care? You're going to wait 10 hours for that broken foot. Go in the waiting room of any hospital in this country and tell me you're not waiting more than 10 hours. And on a bad day, even longer than that. So, I understand the not wanting to trust bureaucracy in the government into kind of handling compensation for medical issues. But at the same time, we have 3 insurance companies. What's the difference? At least the government's goal isn't to profit, where the goal of these insurance companies is to profit. It's not to help people. It's to profit off people. And it's, you, after becoming a parent, and people say this all the time, I worry about my kids. And, I think it's bad now, but how bad is it going to be, 30 years from now? Or 20 years from now. And that's where for the first time, it's just man, things if we can't get good health care here, if we are, again, not to sound like RFK, but if we're feeding our kids poisonous food, when is it maybe living here is not the best thing anymore? And I think that working in healthcare, that sometimes I kind of have that perspective of holy shit, what is going on out here? I don't know. Guess we just hope and pray.
Yeah. It's what's within your control.
Yeah, and I think that helps you go to sleep at night, right? Yeah, I don't want to be some bleeding heart that fixes the world. But when you talk about what's in your control, but also, you know, you can't think of the I can't be indifferent to the amount of selfishness that it just exists of people who's, you know, who are using their talents and their intelligence to rip people off rather than help people.
Curious how they feel about it, you know, the execs of these insurance companies.
Yeah. Well, regardless, folks, of what you think about it, you're not the good guy.
As we approach an hour and a half, is there anything that we've left on the table that we haven't talked about yet?
No, I think Ruthie, this has been a great discussion and kind of not bridging the gap, but kind of understanding. You know, we didn't like directly talk about the procedure, but the notion of like how healthcare continues from the back of the ambulance into the ED, and really like how we really are all on the same team. You know, that one thing you mentioned, that it's just we're on the same team, and I think that's a important perspective to have. I think it's also have a little bit of empathy. You know, that nurse, ECRN answering the phone isn't mad at you. And maybe just kind of brush it off a little bit more and try to take the time to improve just these interactions back and forth. Just be kinder to each other. I think kindness is, you know, sometimes an afterthought. And we all work stressful jobs. And I think a little bit of grace, kindness, and patience goes a long way.
Absolutely.
Vic?
Yeah, this was great, Ruthie. Thanks for coming on. Appreciate the time. Appreciate you still being part of the team.
Yeah. I love it.
We're looking forward to seeing you continue to grow. And you'll be back, I'm sure. Everyone else, thanks for tuning in. We will see you in the next episode. Bye.
Happy holidays.
Merry Christmas.